And thank you for all that have joined us online. Again, remember that we are in a FACA exempt status, so tribal advisory committee delegates, alternates, make sure that we follow that protocol. So welcome back. At this time, I would like to continue the TAC business part of the day, and by opening the floor for discussion on the HHS Tribal Data Policy. The CDC will take notes of what we share, and we will continue this part as a discussion of TAC conference calls. The HHS data policy is included in your packet for easy reference. Your input is valuable as we delve into this, and understand we have had several comments already, but we want to take a little more time to make sure that we get everyone's input. So the floor is open for any questions, comments, and as you see on the board, that is the business items and priorities update that we need to get through, hopefully before our CDC director gets here. Yes, sir. Go ahead, Captain Gilsbeck.
Thank you, Deputy Principal Chief Warner. So as you're aware, we are actively recruiting for our CDC TAC membership. The TAC is composed of 17 delegates and alternates from fairly recognized tribe, each acting on behalf of his or her tribe. 15 of the 17 IHS service areas and national at-large member delegate seats are currently filled. We are actively recruiting to fill the remaining vacant seats for Nashville and Portland delegate positions. Regarding the alternate seats, there are currently 9 vacant positions open in Albuquerque, Billings, California, Nashville, Portland, and 4 national at-large member on the ATSDR. It is imperative to highlight that the alternates are not obligated to have tribal affiliation, matching that of their delegate. For a comprehensive grasp of the alternate role, please refer to the charter, which is included in your packet here. Information for the recruitment can also be found on the CDC Tribal Health website. We'll share a link in the chat box. If you know of any tribal leaders in the areas that we would like to be great contributing members to the CDC ATSDR TAC, please encourage the area to nominate him or her. For any TAC member who do not have an alternate, we strongly encourage you to begin seeking elected officers of a tribal government or a designated representative in your respective IHS areas. Just a reminder that the TAC charter, a designated TAC delegate must be qualified to represent the same area as a TAC delegate, but does not have to have the same tribe as a TAC delegate. The TAC nomination process, candidates must be nominated by an elected tribal leader via nomination letter. Submissions must be signed, nomination letters on the official tribal nation letterhead with the following information to send to the tribal support at cdc.gov email box. Name of the nominee, nominee's official title, name of tribal nation, date of nominee's election to official tribal position and term length, nominee's contact information, mail address, phone, fax, and email, name of elected officer submitted the nomination, official title of elected officer not submitted nomination, contact information for elected officer submitted nomination, and or administrative office of that tribal government. Confirmation that the nominee has the authority to act on behalf of the tribal nations, is qualified to represent the views of the tribal nations in order in the area for which he or she is being nominated. Please be advised that no active subcommittees are currently formed at CDC ATSDR TAC. Deputy Principal Chief Warner, we would like to allocate time to discussing the potential formation of a subcommittee to address a specific priority area identified by the TAC. If the need arises to establish a subcommittee, we'd appreciate the opportunity to delve into the possibility to define the scope of our discussion. Leo, back to the floor to Deputy Principal Chief Warner.
Thank you, Captain Kilsback. And I want to back up a bit and make sure that our TAC delegation gets in time for the HHS Tribal Data Policy. in your packet, if you can turn there, there's a Dear Tribal Leader letter explaining some of the things. And we also understand that we had multiple consultations, but I just want to remind everyone that the CDC team will take notes of what we share, and we will continue this discussion as part of our TAC conference call. So if there's any comments, any concerns regarding this, and just to help everyone along, there's certain feedback on the following questions: which HHS divisions would tribes and TECs anticipate they will seek data from under the initial implementation of this policy? The policy will apply across the department. However, not all divisions have yet full assessment of whether they have custody or control of data covered by this policy. That's just one question. There's several others there. I want to make sure that we spend some time getting those notes. And remember, you can yield the floor to your technical advisor. So. Captain Gillsback.
Thank you. During our last meeting, we explored the idea of adjusting the frequency of our monthly calls to better align with everyone's availability in 2024. The goal is to ensure that the majority can participate and contribute effectively. Instead of holding meetings every month for 60 minutes, we considered a more strategic approach, proposing to have bi-monthly meetings lasting 90 minutes, which will allow us to delve deeper into discussions, make meaningful progress towards our goals, and document results efficiently. Based on our feedback we received via the MS form, we refined the proposed meeting schedule to include the four most popular options. Option 1, Tuesdays from 2 to 3:30 p.m. Eastern Time, the first week of each month. Option 2, Tuesdays from 2 to 3:30 Eastern Time, third week of each month. Option 3, Thursdays from 4 to 5:30 p.m. Eastern Time, second week of each month. And the fourth option, Thursdays from 4 to 5:30 p.m. Eastern Standard Time, fourth week of each month. These options aim to accommodate the preferences expressed by all TAC members, ensuring optimal attendance and engagement during the conference calls. Deputy Principal Chief Warner, I would like to formally request that we elevate the discussion to a formal vote. This ensures that decisions are made collectively and efficiently. I'll yield the floor back to Deputy Principal Chief Warner.
Although Captain Gillsback, at this time, I would like to give the TAC members the opportunity to ask questions or share comments regarding the cadence of a monthly call. TAC members attending this meeting virtually, please use the raise hand feature. And I want to remind everyone that a poll was sent out via email, okay? If you have already completed that poll, then you have casted your vote. If you have not filled out or unsure, you can do a paper vote, and a member of the OTASA group will pass that out to you. So that's just a reminder. Anne Marie, go ahead. Thank you. And so we can do these, and you know, obviously, if I'll just give you one example. I like everybody else to fill in the time, and I'll make sure that I can be there. You know, that's kind of how I roll. So. So if there's no questions, I'll kick off the voting process and ask you to fill out that survey, and we can pick those up once you have completed those. And this just gives us the cadence of what we want to do, and just being mindful. Some of these days work better for some than others. You know, we've got council meetings, and each respective tribe operates a little bit differently from one another. So I try to make my schedule based on what everybody else needs to do. So you go right ahead and fill that thing out how you need to, okay? So with that, once all the paperwork or the paper voting is completed and reviewed, Captain Gillsback and I will confirm the findings and share them with the larger TAC. Due to our packed agenda, we plan to present the results following an update on the 28th Bi-Annual CDC ATSDR meeting. from Dr. Sharon Stanfield. Dr. Stanfield, PhD, RD, Chief Health Officer of the Cow Creek Band of Umpqua Tribe of Indians. The floor is now yours for an update on the 28th Bi-Annual CDC ATSDR TAC meeting. Dr. Stanfield.
Thank you, Chief Warner. Sharon Stanfield, Rep at Large on the TAC, Cow Creek Band of Umpqua Tribe of Indians. Thank you. Well, we are excited to host the next meeting, as you can imagine. It's a lot of work. We are located in Southern Oregon. That's our homelands. And we are just really doing the best we can. We're working with our other tribes in Oregon as well as Emery. She's just been wonderful. We have most of the logistics taken care of for your visit and for us to be able to share our homelands and to share some of the new programs that we have developed around not just public health, but around natural resources, fire mitigation, and things like this that you might find useful and helpful in the Northwest. So we're super excited. We don't have the agenda ironed out, of course. We're waiting until after this meeting and trying to gather what information we need to be able to make sure that we have a robust agenda. And just a little bit to let you know, we at Cow Creek stood up a new public health department, and we are very close. We finished the Pathways program. We're very close to being accredited with that program. So these will just be some of the highlights that we'll be sharing with you. We have a very nice tour that we're going to take you on and just show you some of our part of our homelands and our traditions and cultures. So we're excited about that. If anybody has anything they'd like to make sure we don't forget, please see me, because the 6 months comes quick.
Any questions for Dr. Stanfield? I thank you, Dr. Stanfield. Very much appreciative of you and your time, your talent, your dedication. Can't wait, Oregon. That it's beautiful year round. And we have many Cherokees in that area. So happy to get back up there. And thank you all for participating in the voting process to determine the optimal cadence for the TAC calls. I think let's see. We have not collected these votes, so if you have voted, we will collect those and tabulate that information. Once we tabulate these, though, we'll make sure that everyone gets an updated calendar invite. That way we can get all this on everyone's calendar to make sure that we're operating in the best capacity that we can. Captain Killsback, I'll go ahead and throw it to you so we can continue on.
Thank you, Deputy Principal Chief Warner. The 29th Bi-Annual CDC ATSDR TAC meeting is scheduled to take place in CDC Atlanta, Georgia. 2 potential meeting dates are under consideration for February 2025. Option 1, February 19th through February 20th, 2025, which is a Wednesday through Thursday. Option 2, February 26th through February 27th, 2025, which is a Wednesday through Thursday. I would like to formally request we conduct a vote to determine the most suitable meeting date, allowing ample time for planning processes. Thank you.
Okay. Oh, no.
I'm not, yeah.
Yes. Okay. Ms. Church, I believe you have your hand raised. Okay. Recommended February 26th and 27th. Thank you. Captain Killsback, how would you like to, do we want to just option 1, hands raised, and then option 2?
Yes, sir. I believe that'd be a efficient way to conduct
Okay.
the vote.
All right.
Thanks.
All those that would like to see option one, February 19th through the 20th. And if you do have any concerns on any of these dates, if you can see that far into the future of what might be going on, let us know. But option one right now is on the table. So those who would prefer option one, please raise your hand. Conrad Jacket, raise your hand. Thank you. Okay, option two, February 26th through the 27th, TAC delegation. Yep. Okay. Thank you. And Geraldine Church also says the first date may conflict with IHS budget. So there you go. That was our, yeah. So that is perfect. So it looks like Captain Killsback, if you want to go ahead and confirm what you've tabulated.
Thank you, Deputy Principal Chief Warner. It looks like we have 11 votes for option two, which will be February 26th through February 27th of 2025 for the 29th biannual CDC ATSDR TAC meeting. Thank you.
Thank you. And do we have a tabulation on our cadence yet? Not yet. Okay. Thank you. Well, I know I see at this time that we are awaiting the arrival of Dr. Cohen to give us the director's update. During this time, I would like to open the floor if anybody has anything that they would like to talk about on the HHS data policy. Anything that we've discussed thus far. Remember that our CDC partners here are taking notes and they will take all things into consideration. So. All right, I see none, and I will go back over here. Captain Killsback did talk about subcommittees. There are no active subcommittees that are formed. I know in our TAC monthly calls, we talk a lot about a lot of different things. Is there anything that we can think of? You know, it seems to me the data piece, cumbersome's not a good word for it, but I mean, we want to get that organized. There's some other things that may be on your mind, maybe coming from your point of view from your tribe or your area that may warrant a subcommittee that be formed. So I would like to allocate a little bit of time while we're waiting for any discussions on a subcommittee, and may ask somebody from the CDC, Captain Killsback or anybody, what that subcommittee formation would look like and the formalities of that. If anybody has any information on that, I would be all ears.
Oh, thank you. So yeah, we'll have to look at OTASA, what we can look at in terms of which center can help us with forming such a subcommittee. And so I'll have to take that back with my leadership and see how we can help support any type of formal formation of a subcommittee to help support whatever the TAC priorities may be. It sounds like data is the big issue right now. So we'll strategize with that. Thank you.
Thank you, sir. Yes, and it does. Data seems to be one that I think it would be very helpful, especially for myself, to have our technical advisors set on some type of subcommittee that could be organized like that. That way we can get that, grapple that understanding and move forward and make sure that we get the vehicle right. Well, moving on to our cadence of our TAC, the frequency, our calls, our which day. It looks like the final option on our calls will be Thursday from 4 to 5:30 p.m. Eastern, the fourth week of the month. So that was the vote that was taken. And so again, that is Thursdays from 4 to 5:30 p.m. Eastern time. And that will be the 4th week of the month. So thank you all for voting. And we will make sure that we get that information out to each and every one. So. All right. Okay. Well, thank you all. And for that, promptly right on time, actually 5 minutes early. So Wado for that. Thank you. Yes. So I want to turn the floor over now to Dr. Mandy Cohen, MD, MPH, Director of the CDC, Administrator for the Agency for Toxic Substances and Disease Registry. So thank you, Dr. Cohen, for joining us, and the floor is yours.
All right. Well, hi, everyone. Good morning. Good to see everybody. Thanks for having me in person, Deputy Principal Chief Warner. I appreciate that. I want to acknowledge our team who is here that supports all of our tribal work. I don't know if I see Dr. Dauphin around. I just walked in. Oh, she's in and out. Oh, there she is. Hello. Who has just been such a wonderful leader and continues to be just in her leadership of the Infrastructure Center, a great partner to all of those who we're working with. Wanted to say hi to my friend Connie, who I'm going to be visiting next week in Chickasaw. And sorry, I missed you because of the snow the first time, but second times we're gonna get there. Yes, all right. Historic snow kept me away from Chickasaw a couple weeks ago, but we're going next week. But it's great to be here for my first in-person meeting. Just by way of introduction, if that's okay, Deputy Principal Chief, since my first time with the committee, just a little bit about me and my background. So I'm a physician by training. I'm a primary care doc, but I've spent most of my career in the government space, working either for the federal government or the state government. I was here working at the Centers for Medicare and Medicaid Services during the implementation of the Affordable Care Act. I ran the insurance exchanges. I was at the Innovation Center and ultimately was Chief of Staff and Chief Operating Officer for CMS over 7 or 8 years. And then I went to North Carolina, where I was Secretary of Health and Human Services in North Carolina for 5 years, opportunity to work with many different tribes in North Carolina, spent significant amount of time out in Cherokee. In North Carolina, I'm working there. They've made some incredible investments in their health infrastructure there. And I had stepped down from that role after five years, 2 pandemic years, and got a phone call asking if I would consider coming back here. And it was an easy, well, after I talked with my husband, it was an easy yes, after talking about the family implications. But I'm so grateful to be back in government service and working at CDC on such an important mission to protect the health of this country and really the world. And grateful to be with you this morning. I want to make sure that you hear directly from me to, since it is my first meeting, to reaffirm the commitment of our government to government relationship on behalf of CDC. I know there's been a lot of good work, and I think actually CDC is very good at, we do a lot of global work in government to government interactions. And I think we bring that asset to this work as well. I want to make sure you hear from me that we support and respect tribal sovereignty and self-determination for tribal governments in the United States. And I look forward to making sure that we have great collaboration as we all work to protect and improve health across all of our the folks that we serve. So I thought I would start by talking a bit about our priorities for 2024. I wanted to spend some time celebrating what we did in 23, but I think best to look ahead to 2024, and maybe I'll throw in a few ways in which I've proud of the team as we're going forward. We have 4 priority areas. And the first one is, as we come out of the pandemic and have learned some very important lessons about how we can be the most effective CDC possible. One of the most important is that we CDC operate as one team, and that we focus on collaboration, equity, and accountability. We know that we have to be great partners. We cannot, protecting health is a huge and enormous mission we cannot do alone. That has to be a partnership and collaboration, whether it's our government to government partnership and our tribal partnerships, or ones with our states, the healthcare industry, the private sector or others. We have to do that collaboration. Equity needs to be at the center of all of the work that we do. CDC is grounded in that. I'm actually incredibly proud to join that organization, and I see equity embedded in every piece of the work that we do. And I want to talk about some of the ways in which I was really proud to see that equity work shine, particularly related to tribal work. And accountability. Impact matters, right? And moving the needle to improve and protect health is what we need to hold ourselves accountable to. We have to recognize the unique public health needs of American Indian and Alaska Native communities as we do that work. And we are certainly committed to making sure that we have regular and robust tribal engagement. And I know that our new leadership is going to make sure that we can continue some of the important work that we've done together, whether that's the Healthy Tribes Program or the Tribal Public Health Capacity Building and Quality Improvement Cooperative Agreements, that structure that allows us to do our work together, or others, and I'm going to talk about related to our data work or our Grants Governance Board to continue to make improvements. These are all part of the foundation of us, CDC, being a great partner to our tribal communities. The other priorities for us as we work forward are to think about making sure we are ready to respond to any health threats, whether that's a respiratory virus or a wildfire. We need to make sure that we have the core capabilities or the infrastructure to respond to any of those threats. And we cannot do that, again, if we do not have partnership. I want to acknowledge the incredible work that tribes did during the COVID pandemic. I saw it firsthand in North Carolina, but I've certainly heard from our teams about how much work has gone in to protect your tribal communities. The vaccination work that was done is really incredible. So thank you for that. And so how do we take that and think about what is the readiness and response that we can continue to do together as we look forward into 2024 and beyond? The good news from a COVID perspective is we are in a different place. Luckily, we not only have the tools to protect folks like vaccination and testing and treatment, but we also know from the science we have underlying immunity across a population now, where 98% of us have either gotten vaccinated or had COVID. And that puts us in a different place in how we can think about COVID going forward, which is great. But we need to make sure that we are continuing to use those tools. So as we think forward to the future, how do we continue to have vaccines not just scientifically available, but actually truly accessible to folks? I think, the CDC stood up in record time the Bridge Access Program that allowed for free COVID vaccines. I know we worked very closely in partnership with tribes and the Indian Health Service and others to make sure COVID vaccine was available. And for the first time, in this season, we had vaccines against RSV. And as you know, RSV is something that impacts our Alaska Native and American Indian populations in a different way. We know that that babies that are American Indian or Alaska Native have higher risk of having bad outcomes if they get RSV. We see it in our data. Again, that is CDC data and work that we've done together to understand that. And so when this year, for the first time, we had an RSV immunization for our babies, I was really proud of the team to make sure that we were doing focused work with you all to make sure we were recognizing that disparity that was out there in terms of severity of disease for RSV, but that so for example, we reached out and you all gave us input ahead of our vaccine advisory committee meeting to make sure that they recognize that difference, and it got embedded into the recommendations that came out for babies and young children. And so it meant that every child through the VFC program who is under 20 months can receive a shot for free. And that is different than the general recommendations for the population, which is any child under 8 months. So we recognized a difference in the disparity. We used that data to make differentiated recommendations, and that flowed through our work and our operations. And then you may know we had some supply challenges with that RSV immunization this past year. So the manufacturer did not make enough supply. And so when we saw that, again, recognizing the disparity in which the virus impacts our American Indian, Alaska Native populations, CDC immediately went to make sure that we could get that immunization to those communities in a preferential way. So we wanted to make sure that even with that limited supply, that we still got the supply to those who are at higher risk. And I know that, again, that was a great partnership and a way in which you are seeing our data, our partnership, and then the operations all come together to make sure that our tribes are represented, are seen in all of our policies and recommendations, and most importantly, that our children are protected. So I was really proud of that work. And again, thank you for that partnership. And I hope you will just see that as an example of how we can continue to do our work in terms of response effort together, to actively work with our colleagues, all of us, to make sure that we are doing it. I think that is something we need to take now, for example, to our work in syphilis. We also know there is a disparity there, and how can we also use our data, statistics, collaborations to make sure that we are reaching appropriate populations. So that's one big area of work, our readiness and response that we do here at CDC, and again, takes partnership. The second area of focus is around improving mental health, and particularly making sure that we are getting upstream and preventing mental health challenges, and particularly preventing overdoses and preventing suicides. We are whereas in the response area, that is where CDC is certainly the quarterback. Mental health, as you know, there are a lot of important partners across the United States government who are thinking about improving mental health right here at HHS, whether it's SAMHSA, HRSA, CMS, all thinking about improving mental health. But CDC has a unique role to play in improving mental health by bringing the best data, evidence, and best practices to bear and partnering with folks. And so we're making sure that we can partner together, that you all have the best data and evidence and tools to protect your communities from overdose, suicide, and other mental health challenges. The last area of focus is in supporting young families. So we had response and readiness, we had improving mental health. And the third area of focus is supporting young families. And this is where I think our prevention work really shines. We are a Center for Disease Control and Prevention, and we need to get upstream to make sure that our communities are the most healthy they can be, whether that's protecting mom while she's pregnant or having her baby and thinking about maternal mortality. I know at your last meeting, you got an entire briefing on that maternal mortality review. So thinking about protecting mom during pregnancy, or it's making sure our kiddos get their routine vaccination. The good news is we continue to see high vaccination rates. 94% of children are getting their vaccinations, but we cannot take our eye off the ball. I think we all are seeing in the news the cases of measles and others we don't want to forget. But we also have to make sure that our parents, the caregivers are also healthy, right? So thinking about, are we supporting our parents, making sure we're doing things like diabetes prevention, making sure that we are doing that work on smoking cessation, right? So that is where this work goes to support young families, really helps us. So those are the three areas of main focus after focusing on making sure CDC is the best partner it possibly can be to you all. I wanted to touch on two other issues, just knowing that there were questions the last time. And so maybe I could talk about those two areas in anticipation of some questions here. One is around data and the other is around the grants process. And I met with STAC leaders at the HHS STAC meeting, and we talked specifically about these two issues amongst others. And I continue to appreciate the feedback and conversation. First, around data access. I really appreciate you all leaning in and helping improve our data access and quality and giving feedback, particularly when we needed to hear some hard feedback where policies may have been going in the wrong direction. And we needed to maybe put that aside and start over, and that's okay. And say, what do we need to do? I think, are investing in the tribal epidemiology centers and trying to understand the complexity of introducing yet a new entity into the mix on the data quality and data sharing issues, so need to work through that. But we're putting a lot of focus on improving our data infrastructure that I think lifts all of us as we do that work. And so I want to say out loud that we recognize the importance of sharing data with our tribes and making sure that we can get to a place where you are seeing the data you need for your communities to keep them healthy. And so we are working on ways to streamline our processes to respond to data requests, as well as our tribal epicenters, so that we can facilitate that data access and transfer in a timely way. We continue to support, from a dollars perspective, investment in some of the data modernization efforts. And I know you're going to hear more about it, or I don't know where in the agenda it was, but from our head of our data work from Dr. Jen Layden. But we are continuing to provide some investment of dollars. We provided $750,000 across 3 tribal public health partners since 2020. And we've invested more than $7.5 million total across 26 partners, but made additional investments this past year. I know that there's been some great work. I had some examples from the team around Northwest Portland area Indian Health Board that implemented a strategic framework for guiding the future of data modernization, or the Little Shell Tribe that invested in modernized technology as a foundation to manage that data, or the other work that we're seeing across tribes. And we recently, that CDC participated in a tribal consultation on that draft tribal data management policy. And I just want you to know that we heard that input from tribal leaders regarding their tribal data use and access concerns. So like I said, we're hearing that feedback and really are thinking about it. That was an HHS data piece. And I think we are learning lessons from even that feedback to HHS as we work on our data and tribal data management policy here. And so you're going to hear more about that, but we hear folks on needing to make sure that data accessibility is part of what you need. On the grant side, I want to acknowledge the feedback that we have heard that the grant process itself has been burdensome. I know Dr. Daffin has shared with the TAC that we did establish an internal grants governance board to look at how we can streamline and improve the process. I know they held a tribal listening session on December 6th to receive input. Some of the things, so you know, that are on my radar, and I heard about the need to account for the differences in tribal governance as well as the delivery systems, so that we just have to think differently about how the funds flow, as well as the models of how we think about that together. So again, this is going to need to be a collaborative process, because we of course, because we all have folks who are our bosses. We certainly need accountability for those dollars, but we have to recognize the differences in how you all and the tribes are working, and we want to be good partners there. So I wanted to commit to you about how we will continue to work on improving that process. That is not something that is exclusive to tribes. We want to be improving that grant process for our state partners and our localities as well. But we have more work to do. So thank you for all of that feedback. In closing, again, I just wanted to reinstate how important the government-to-government relationship is with our tribal nations, and reaffirm our commitment to open and transparent communication. I wanted to thank our teams at CDC again. I think they are continually working hard to represent the feedback that you're hearing and to work through and solve problems. And with that, why don't I stop there, and I welcome feedback and input from leaders, and then I'm certain I will learn even more next week when I'm on the ground in Chickasaw.
Well, thank you, Director, and from the TAC delegation and all of us, it's an honor to have you here, and we're very appreciative of your time. And you know, there's so many things. Before I open the floor up to the TAC delegation, I just have a few comments and things to say. As you may know, tribal nations are sovereign governments, obviously recognized under the Constitution of the United States, treaties, statutes, executive orders, and court decisions. Has the population with many of the most severe health inequities, and the only population for the United States for which the United States has legal responsibility for health, the CDC leadership must continue to prioritize its relationships with tribes and improving the health of our people. However, there's been times where we may have experienced or heard of experiences or examples where the CDC operating divisions either neglect tribes or engage inappropriately with Indian country. We feel strongly that more training and strengthened policies and commitment are needed across the board to ensure that all CDC directors and their staff understand and prioritize the government-to-government relationship and the federal trust responsibility for Indian health. We feel that the purpose of the CDC Tribal Advisory Committee is to be one of the tools used to facilitate the government-to-government relationship. Your good faith, robust engagement with the TAC is an excellent way to lead by example and demonstrate that tribal public health is a priority for the CDC. I have a few other things that I would like to add. First, the CDC must consult with the tribes on the execution of Executive Order 14112 and reform agency policy to design and administer federal funding and support programs for tribal nations in a manner that better recognizes and supports tribal sovereignty and self-determination. This means providing direct funding when possible and working with Congress to revise any legislation that stands in the way of promoting tribal self-determination. Now, second, and I call this it's kind of the one size fits all thing that we found ourselves in when it comes to tribal public health infrastructure funding. All of our tribes that are represented here are unique. When you think about Indian country, I want you to think about the totality of the United States, all of that land that exists, that is Indian country. So when you visit and you drive, you are in Indian country. And I appreciate you going to the Chickasaw Nation and encourage you to go see other nations, because when we start talking about funding, you don't always think about money. And money is not the root of all evil, but the love of money is the root of all evil. And we don't want to fall into these pitfalls and so forth. So when you think about tribal public health infrastructure, I still want you to think about that tribal government, because that tribal sovereignty is what dictates out of that. And then, we have these functions, these things that were set up like tribal epicenters. We have our tribally led organizations, NIHB, for example. These organizations are very important to what we do. Some tribes, when you think about tribe funding, you think about that direct funding to the tribe, and we want to make sure that we ensure that we always instill that idea, because tribes know best what to do with their money, and other tribes, they need it. At this moment in time, public health capacity is different for each tribe. Some are on a level just because of the fact of where they were situated and what's happened to them. Other tribes need that help. So I want to make sure that is the overarching thing when it comes to implementing the growth necessary to build our public health institutions. You think about a tribe, the funding that's troublesome sometimes is when we see funding that goes to help tribes that goes to a non-tribal organization. That becomes problematic. That's up to each individual tribe when you think about that. So that direct funding stream to these tribes is very important when you talk about our government to government functions when it becomes funding. Third, we feel the CDC must use every tool available to improve tribal access to essential public health data, including ensuring any new or revised data use agreements with states and other jurisdictions support tribal sovereignty and tribal public health data access. When I think about data use agreement, Lisa Pivick and our team at the Cherokee Nation has been interested in looking at these data use agreements, because we understand you have them for the states, and states often do not have to have the tribes come to the table, but yet they get to use our data. But when we get the funding, we've got to go seek, information from the states. And sometimes it just depends on the relationships that are going on a lot of times in that. And I know our time is of the essence, and I know many others have things that they want to say. Lastly, the CDC must elevate and prioritize relationship with tribes, through improved consultation, engagement with tribal advisory committees, and by elevating the Office of Tribal Affairs and Strategic Alliances within the Office of the Director. I was looking earlier, Director Cohen, at the number of vacancies that are within OTASA, and sometimes that becomes problematic. I don't know what that issue is, but I feel like if we elevate this and we have that under the Office of Director, I think some of the cumbersome things that we all encounter will become less cumbersome over time and less bothersome. Those are just some of the topics that I have, and I do want to, before I go to our other TAC delegations, I want to give Dr. Dauphin a moment of time. Yes, ma'am.
Thank you. Thank you, Deputy Chief. I really appreciate it. And Dr. Cohen, want to thank you for your leadership. We are very fortunate in that we have a director that is so supportive of CDC's work with tribes and tribal serving organizations, and actually demonstrating her commitment to support tribes and TSLs through her presence and engagement, and making clear expectations, setting clear expectations for CDC leaders, particularly our center and our work across the agency. I did want to just speak on two of the topics that Deputy Chief Warner raised, just for awareness of all, The first is around OTASA. And I thank you, Deputy Chief, for raising and elevating that we do have a number of vacancies in CDC's Office of Tribal Affairs and Strategic Alliances. And I want to highlight that one of the reasons in which you see that we have vacancies is that, one, we want to make sure that we get the right support to help with what you mentioned in educating and working with our colleagues across the agency and in that government to government space and in the interagency space. The second is I wanted to highlight that we've actually allotted more positions to the office because we recognize that we needed more staff to support this important work. So that is another reason why you see the vacancies there. We are delighted that under Captain Killsback's leadership that we will be able to attract and retain the right staff to help our Office of Tribal Affairs and Strategic Alliances be helpful. I did want to also raise the point about strengthening our interagency relationships. One of the things that we've been able to do recently, and also with the support of Dr. Cohen, is affirming our relationships at the interagency level. When we met last at our TAC meeting, it was raised that CDC should be out working more with other agencies like the Indian Health Services and CMS on working on policies and practices that will benefit tribes and tribal serving organizations. I wanted to tell you that we have heard you. And since that time, CDC has been engaging very closely with IHS. In fact, just last week, we met with them to talk about some of our work in the immunization space. So I did want to address that before we get on to our tribal leaders. I know that Dr. Cohen is here for a moment, and I just wanted to say publicly to all of you that we are really fortunate to have a director that's really showing and demonstrating her commitment to our work in this space through her time and effort and through her leadership. And Deputy Chief, I will turn it back over to you to facilitate questions from our TAC members.
Yes, thank you, Dr. Dolphin. Much appreciated. As always, your comments are always very much on point. Director Cohen, do you have any comments before I turn? Okay. All right, TAC delegation, the floor is open. So remember, if you are on virtual, please use the raised hand function. Also a reminder, state your name, the area that you represent. And one more reminder, you can defer your time to a technical advisor. So the floor is open. Dr. Stanfill.
Thank you, Chief Warner. Thank you for attending. Appreciate it. And happy to get to know you better and to know your investment and your dedication to Indian country. I'm Sharon Stanfill. I'm the Chief Health Officer of Governmental Affairs for the Cow Creek Band of Umpqua Tribe of Indians, and I'm the rep at large on the TAC. And the first thing I wanted to bring up, I think, kind of is the foundation of the TAC. And I want to reemphasize what Chief Warner stated about the foundation of this TAC and the value and expertise that we bring. It's just one piece of the government to government. It doesn't by any means substitute for government to government relations and consultation with nations, urbans and confer and such, but it is one means. And I appreciate that we have this committee. Something that is really, really important is because we wear a lot of hats and we come and we're trying to bring our expertise here and help represent our nations, is financial support to technical advisors. And with us in the room is our our National Indian Health Board. And these folks help us. They invest nearly 100 hours, probably more than that, to get us prepped for each of our meetings. They help our co-chairs. They help our TAC members. They provide us, we have caucuses, we prepare talking points, and we get ready for the meetings so that we can have good use of the time. And they used to, in the past, we funded them, the CDC, and that hasn't happened. The vast majority of the work they're doing is currently going unfunded. It would really be great if we could have a commitment that they could be funded, that we would have their time and getting ready for meaningful engagement, that we could have that commitment from the CDC for our technical advisors. Thank you.
Thank you, Dr. Stanfill. Any of our other TAC delegation? Yes, sir. Assistant Chief Dale Beaver.
Good morning, Dr. Cohen. I appreciate you being here this morning. And just this group's probably going to get tired of me saying this, but if I'm going to say it once, I'm going to say it a dozen times. It's about tribal sovereignty. And you know, there is a trust responsibility that the federal government has to all Native nations. And that while I'm sure tribal epicenters have served a purpose, you know, we're not a tribal epicenter. We are a health system. You know, we have a very robust health system, and I can't speak on behalf of the other tribes in Oklahoma, but I can attest to them though, just by my viewpoint and my perspective, and that and I think a lot of tribal leaders will agree with me that back in Oklahoma, when COVID came down and the vaccines came down, the tribal nations were the first ones to give out the vaccine, and we did it in a better manner. We were more in a better expedited manner than the state did. We were at the forefront of these things. And so that, to me, that's that just gives credence to that when there's something wrong in our communities, the first ones to know is us, not the state, but it's us. There's not private entities investing millions of dollars of healthcare into our rural areas. It's the tribal nations investing millions of dollars into our rural areas and nobody else. For a 10-year period, there's rural hospitals closing in Oklahoma while the tribal nations were opening health clinics in Oklahoma. So if you want to talk about investment into our communities, it's the tribal nations. And so I was looking at the CDC's mission and help us help you. That's what it boils down to. If you want to know what's going on at the local level, it's the tribes that's going to know and nobody else. And so, because really that's our mission, is to protect our people and to serve our people. And so this goes right along with the CDC's mission. This goes hand in hand in what we want to achieve. And so if that line of communication directly to the tribes can be improved, however that may look, it would help the CDC's mission, I guarantee it. And so I just would like to say that on record is that the tribes know what's best for our people. The tribes know what's best for our communities. And if you want to know, CDC wants to know, come ask us. That's all you have to do. But like I said, yes, if you just observe and from our viewpoints, and Chief Warner, you can attest to that also, tribal nations, we are it when it comes to rural healthcare in Oklahoma. But
Thank you, Second Chief. Yes, Ms. Frias.
Good afternoon or good morning. Thank you, Dr. Cohen, for joining us today. I'm Councilwoman Edvinia Frias, that delegate at large, and also council member for Basco Yaqui tribe. I just want to, I know that you talked earlier about the grants process, and you talked a little about, you understand the burdensome process around that. But I just want to emphasize a little bit about that too, because, going back to also what Second Chief was talking about as tribal governments and sovereigns, we still, I don't think it's still recognized about how burdensome it is, that there isn't that pass through. And we're still not recognized as sovereigns in some sense when it comes to that we still have to go every year and go back and or when the grant expires and ask for this funding again, when states are just giving pass through for funding. And it is burdensome because if you don't understand the process as a tribal leader, they've got to go back and they've got to reapply, and they've got to go through a whole tribal council meeting. And you've got to get all of these things done in a short timeline sometimes. And as our tribal council, we're pretty efficient. We have regular council meetings and we can get stuff done, but things happen and it is burdensome. So the fact that it's not recognized as that we are sovereign and that the states are in these logistical matters like this is still unbelievable. So I just want to emphasize that, because we are talking about public health. We are talking about people, and I know you understand that. And, you know, when it comes to these resources and this funding, it's about what we're doing to take care of our people. And so it's about what we're doing as leadership to ensure that this is a process that's taken care of, and so that the people that are actually doing the work are taking care of our people. So what is it that we need to do to ensure that we can finally get that pass through, and we don't have to go back after the grant expires, and that it is the same process that states have been getting every single time, and that equity that has been talked about is really there. Thank you.
Thank you, Council Lady Frias. Any other
Deputy
of our
Principal Chief,
tribe?
Do you want me to maybe?
Yes, Director. Yes,
don't
ma'am.
wanna
The
take
floor
up-
is yours.
So maybe just a few to respond first. Dr. Sample, thank you for that. Let me go back to the team and understand sort of the history and where we are. But I hear your request. And I also wanted to thank you for recognizing the link to the health system investments within the tribes. I did see that firsthand when I was in Cherokee. Like, they made some incredible investments. So I have firsthand witnessed that. I will say that is a place CDC needs to get better across the board, whether it's with our tribal health systems or the healthcare system in our states as well. So thank you for highlighting that. I think it's really important, and hear you in saying we know where the challenges are and how do we make those links together. And thank you on the grants process. I want to better understand the differences on how the state process works. And I'm going to get into a little bit more of the details, because I'll say I hear from my state partners that it doesn't work well for them either. So we need to make progress across the board. And I will say, coming from the state, I think there are improvements across the board, but I'm hearing you say we even need to get to a parity from that process. So I'll understand that a little bit better. And I know Dr. Dauphin and the team will dig into this with this review board, and to understand how we can, and help us figure out how we can find the right middle ground here of making the process easier, but still having the visibility and the accountability as we do, right? Because I have to go and answer to Congress for the dollars that we're spending. And so making sure that we can find that balance. And I think that is doable with good communication. And so hear you on those issues. Yep.
Thank you, Director. Anybody else? Any more comments? Yes, Legislator Barker.
Connie Barker, Chickasaw Nation, Tribal Co-Chair and representing nations at large. Dr. Cohen, I'd like to thank you again for the attempt to try to get to Oklahoma and see Chickasaw Nation back when only one day of the winter we had ice, and it happened to be on that day. So we're going to try that again, but I appreciate the effort you made to come and see firsthand how tribes take care of their own, and just bragging on the Oklahoma tribes, for their healthcare. I have worked 40 years in private healthcare, and I can tell you tribal health is some of the best in the United States. They do, they drill down to the patient as being, like you said, a person, what's wrong physically, what's wrong emotionally, what's wrong, holistically. They just put so much time and effort into treating that citizen as the only citizen there in, seeking healthcare. So, I just really want to brag on our Oklahoma tribes for what they do. And just, to say some of the smartest people I know are tribal citizens. They're educated. They want to put time and give back to support their citizens in their tribal nations. So coming to visit, I want to thank you again for that. Look forward to being able to show you the hospital and brag a little bit about the new hospital we're building, because we do see the need in Oklahoma for additional health care for our tribal people. And so hopefully we'll get to emphasize that. And just want to thank you again. I realize that you have a huge job. You don't have to answer only to tribal governments, but also to, Congress. And I realize that, that's a mess right now. Sometimes, your hands get tied there. But we do appreciate the effort that you're putting in. We hope that we'll be able to work together, government to government, and looking forward to doing that. Thank you.
Thank you, Legislator Barker. Anyone else? Yes, ma'am. Ms. Russell.
Thank you, Chief Warner. Kim Russell, alternate for Navajo Nation. I'm the Executive Director for the Navajo Department of Health. Coming from my tribe, Navajo, we're a huge nation. We span 3 states, New Mexico, Utah, and Arizona. Our population is upwards of 400,000. So we have a huge population to serve in 3 different states. So you can imagine the various jurisdictions that we have to consider, not only state, but county jurisdictions. I just inquired with my staff as to what is the presence of CDC within our nation. And of course, you heard of what we had to go through with COVID. That's still something we are recovering from, we're still healing from, and I know it'll take many, many years for us to do so. And one grant we have for $300,000. And then the other one's probably about the same amount. And that doesn't make sense to me. I don't think that's anywhere near equity. So from my nation, we have a huge need for support. I think it was mentioned earlier, the technical assistance that we need. Of course, our partners with National Union Health Board, but just any other expertise that we could have to build that public health infrastructure would really be welcome from our nation. We have infrastructure that's really never been invested in. And when we talk about the disparity in funding between state governments and tribal governments, I used to work for state government for 10 years. And all the time, that's what we saw. We saw funding come to the state, and as tribal workers, tribal advocates within state government, we could just see that money sit there and go out to counties. And it would bypass our tribes all the time. It was mentioned earlier as well that the state and counties use our population numbers for grants, right? I come from one county, Apache County, from my nation, and over, I'd say, 8/10 of that county is Navajo Nation, and also the population. But the numbers that come for that county is that whole population, right? So we can see that inequity there when it comes to funding. So my request really is just, I think it's already been said, is just to treat us as sovereigns, first of all. I think that's what we've heard time and time again, and we'll continue to say that. But we're here today, and I guess a request from my nation, being one of the biggest nations, is how can we really be at a level of funding and technical assistance so that we can build our infrastructure? We really are lacking. I've been with my tribe for about 8 months now, coming from state government to here, so I can compare the two. And we really are lacking. It's really hard for us to talk at the same level with them, but we really try to do so. And I'll give you an example. I want to talk a little bit about our workforce as well, which includes the public health infrastructure. In regards to our public health workforce, we are hurting in that area. One of the areas would be like our epidemiologists. All the talk we had today about data, I am hurting and looking for epidemiologists. So if there's any support you could provide our nation in that regard, that would be very, very helpful to our nation. But again, just in closing, we just really want to work with CDC in a very meaningful way. And I'm going to take a look at what we have funding for this year, and I hope to see that funding increase with your commitment from the agency here and with all of the different offices you have. So thank you.
Thank you, Ms. Russell. Anyone else? Well, Director, do you have any comments?
Well, just to reiterate, this is incredibly helpful. I want to say I hear you on the importance of the government to government, the sovereignty piece, and on each of the topics, no matter what it is, that is the through line as we work through. And I know that our team and Dr. Dauphin is like incredibly attuned to that and sensitive to it. But it is really helpful for me to hear even again, right? Because I have a mental model of how we did some of our work in North Carolina. And I know that is, to your point, like there is not a one size fits all. It is, and that folks are at different levels of maturity and investment in their programs. And so that how do we both think about running a national program and getting to the individualized nature of what is needed for each of the tribes. So that's work to do. I want to take that back for the team. And I know we have some work to do. So this is incredibly helpful. And again, looking forward to learning even more next week when I'm on the ground in Oklahoma.
Well, thank you, Director. And, before my final comments, I want to say my apologies to Dr. Dauphin. I stole her introduction to the director here. So
Oh.
Dr. Dauphin, I promise I'll make it up to you.
Thank you, Deputy Chief.
It's
I
these,
appreciate all that you do in our partnership. It's fantastic.
but no, Dr. Dauphin has been remarkable in her position. She takes time. We have monthly calls with Legislator Barker and myself to make sure that we get in tune with what we need. I want to put this thought in your mind of, you've got a great opportunity here. I know the gravity of the position that you're in. Nobody can understand it more than you and those that have came into this, but the opportunity to find that added value and that big time value across the United States, across Indian country, that partnerships with tribes, our government to government relationship. Some of the initiatives there are paramount that the more that we foster these relationships, the more success that you will have, the more success that your departments will see, and the better that we'll all feel, the healthier the entirety of our nation. I want you, when you think about Cherokee community values, that GADU gets working together for the greater good. But that entire list of Cherokee community values is all about loving one another as you love yourself. One of the ones that sticks in my mind is hold one another's existence in high regard, is stingy with one another's existence, just as a mother is with a child. And that's so important. That embodies everything. That's not just Cherokee community values. As I start to listen to all of our other tribes, they have the same regard for our Native community, our other Native neighbors and cousins, and our other non-neighbors. And because when you look through the pandemic and how tribes really lifted up that area. But again, I just want to say thank you for your time, for your talent, your dedication. Your presentation was wonderful. And I don't know if you understand the level of how important it is for your presence here today. That is big time. And we always want to welcome you to any of our monthly calls. I understand busy schedules and everything, but please, and thank you for taking that time to come to Oklahoma and so forth, and that level of understanding. But we all have a great opportunity to see a lot of success. And a lot of success is dependent on tribal members that have worked as employees for the CDC. We've already heard presentation this morning and so forth. So it's really exciting. The difference that we can make, as Ms. Satter said, in the next 100 years, where are we going to be? What do we want to do? So again, what don't from me to you. So before we break for lunch, we'll be taking some group photos. I know everybody's excited, right? Group photo time. The OTASA team will guide us to the designated location for pictures. Then the TAC is invited to join CDC leadership for a networking lunch, and escorts will guide us to the lunch area. For TAC members and the CD staff that opted to pre-order lunch, your lunch will be set out at the lunch area. Your name will be clearly labeled on the item so that I do not get your food. And in order to get that final order. As a reminder to all TAC members and their representative teams, if you're not already signed up for one of the 3 lab visits, as a part of the cultural enrichment activity, please do so now. Each lab tour can only accommodate a total of 15 people. So thank you for your attention. So now we are adjourned for lunch. We will return back sharply and promptly at 1 o'clock, but let's go take a group photo. So don't.